Morning, everyone. Welcome to today's program, Healthcare Reform. Is it healing Massachusetts and the nation? My name is Roberta Schaefer, and I'm the president of the Research Bureau. We'd like to express our gratitude to the Mass College of Pharmacy and Health Sciences for hosting today's event. And to greet us today is Mark Fuller, who is the chairman of the George F. and Sybil H. Fuller Foundation and a trustee of the college. Mark?
Good morning. On behalf of President Charles Monahan and Vice President Dennis Lyons, who is Vice President for the Worcester and Manchester, New Hampshire campuses, we do welcome you here this morning. We will, by this time next year, have about 1,000 graduate students here in Worcester. And our newest program, Doctor of Physical Therapy, just opened up in September down at 10 Lincoln Street, the old Crown Plaza. And the school in total has about 5,500 students now. Here in Worcester, primarily Doctor of Pharmacy, physician's assistants, nursing programs, the new physical therapy program, and next year, starting in September, the second School of Optometry in New England will be here in Worcester. So lots of growth, and for those who've already asked, yes, there is a crane down there at 10 Lincoln Square, because where the old pool used to be, that has all been cemented in and is now the foundation for a new 6-story building, because we've already found that we have completely filled out that entire space, and we'll be building a 6-story building there for future capacity. So, on behalf of the college, I welcome you and good morning.
Thank you, Mark, and the Research Bureau is really most appreciative of the generosity of the college in lending us this space on a regular basis, and in all the other things that you folks are doing in Worcester. And I also, of course, want to thank the Fuller Foundation for its support of the Research Bureau over many years. Today's program is part of the Research Bureau's Francis Harrington Forums on Municipal Government. And we are very grateful to our 2011 presenting sponsor, Commerce Bank, and our 2011 leadership sponsor, Bowditch & Dewey. And today's program, today's event sponsor is Harvard Pilgrim Healthcare, which is setting up a new presence in Worcester in just a couple of weeks. The Research Bureau also wishes to express its appreciation to the Telegram and Gazette for advertising today's event and to the City of Worcester's government channel for videotaping it. And please be sure to visit the Research Bureau's website, wrrb.org, where you can read about all our upcoming events, and all our reports are online as well. And with the generous support of all of our sponsors, we'll continue to offer these, what we hope are very provocative programs. One other point that I wanted to mention is that the Research Bureau is now accepting nominations for the 2012 Thomas Green Awards, and information that's for public employees, where we recognize outstanding public employees. And the information about the program and the nomination form are available on our website. So please, we hope that if you know of somebody who is deserving of this award, all the information is on our website, and we hope you will consider nominating someone. It's now my privilege to introduce today's moderator, who really needs no introduction here in Worcester, and that's Eric Schultz. Eric has been the president and chief executive officer of Harvard Pilgrim Healthcare for the past year and a half. And during his 26-year career in healthcare, Eric has consistently taken an active role in defining and implementing changes that have led to improvements and greater efficiencies in both cost and delivery of health care. Prior to joining Harvard Pilgrim, as all of you know, Eric was President and Chief Executive Officer of Fallon Community Health Plan for 10 years. Under his leadership, Fallon emerged from significant financial losses and transformed itself from a regional group model health plan into a statewide healthcare services company. He's also held positions with Cigna Healthcare, where he oversaw the operations in eastern Missouri and southern Illinois, and with Prudential Healthcare, where he led its Nashville and Memphis commercial and Medicaid business. He also served as medical group administrator for Nashville Healthcare Group and was responsible for building a clinical delivery site for Nashville's largest primary health care practice. Eric serves on the boards of the Kenneth Schwartz Center, America's Health Insurance Plans, the Massachusetts Association of Health Plans, and of course the Worcester Regional Research Bureau. He also served as chairman of the Research Bureau from 2004 to 2007. He's a past president of the Mohegan Council of the Boy Scouts of America and holds the honor of being a Distinguished Eagle Scout. He has an MBA in healthcare leadership from Yale University School of Management and a bachelor's degree in both science, in biology, and a Bachelor of Arts degree in economics from both from the University of Connecticut. In 2009, he received an honorary doctoral degree from this institution, the Massachusetts College of Pharmacy and Health Sciences. Please join me in welcoming Eric back to Worcester.
Got to bring this one up a little bit, Roberta. Good morning, everyone. It's nice to see so many smiling faces on a Monday morning. We're talking about health care and health insurance. I'm glad to know there are other gluttons for punishment other than myself. It's really good to be here with you today. All kidding aside, health care and health insurance, its cost, its delivery, is a subject that is so important to all of us in the room, both from a professional perspective and also from a personal perspective. There are so other instances where the overlap of our professional and personal lives are so significant and so meaningful. And so I am really glad that you are all here to join us. I thank the Research Bureau for presenting this forum, and just to echo Roberta's comments, our support from our many funders and the Mass College of Pharmacy. So thank you. A couple of comments before I introduce our first speaker. It was back in 2006 when Massachusetts enacted its landmark healthcare reform legislation. The purpose of this legislation, as you all know, was to get everyone covered in insurance here in Massachusetts. Now, the numbers of individuals that were supposedly non-covered, I say supposedly, it was very difficult to count, was somewhere between, 500,000 and 700,000. Some of you may debate that, but that in a state of about 7 million people, you can get a sense of what those numbers are. Now, today, the statistics are suggesting we now have 98% of the Commonwealth covered with insurance. Take 2% of 7 million, that's about 140, 150,000. So if we've gone from 700,000 not covered to 150,000, not bad. Now, how much did that cost us to do? That's another one for debate. Now, keep in mind also that Massachusetts, for many significant reasons, was, I think, the leading state of covered insurance, of lives that are covered by some form of insurance, whether it's Medicaid or private insurance. So we do have a very rich history, one that we can be very proud of. Now, this law that was passed back in '06 was called Chapter 58. It's a very exciting name. It includes mandates, one, requiring all residents with the financial means to have insurance. You have to have it or you pay a penalty. It required all employers with 11 or more employees to contribute toward their employee's plan or else pay a penalty of about $295 per employee per year. It also expanded Medicaid to cover more individuals And it also established something called Commonwealth Care, which is a subsidized insurance plan. It's very progressive. Depending on how much money you earn, you would receive a subsidy that decreases as your own financial status increases. The law also created an exchange, which is called the Massachusetts Health Insurance Connector, which helps individuals who do not qualify for Medicaid to purchase competitively priced plans. It's also in place to help bring commercial insurance to the small employers in our marketplace. In a recent study by the Beacon Hill Institute, it's estimated the healthcare reform, on average, has driven total health insurance costs up by $4.3 billion. Now that's a number, it's a big number, and it's a number worth examining. The study that was completed, I would advise or suggest you to take a look at it. It's provocative in its own right. But this additional cost was raised for a variety of reasons, certainly those that come to mind: cost shifting. Medicaid reimbursement's very low. It's far below the cost for providers to deliver care. Where are those providers seeking the difference on the commercial side? You employers are helping to pay for that. So that made your insurance costs go up. A required minimum creditable coverage that was much richer than 700,000 people in the Commonwealth had. So they had to buy more rich benefits. And of course, the underlying medical cost trend. Massachusetts, unfortunately, has the position of being the most expensive state in the country for delivering care per person. Now, the last point I would make here is that when this debate began, which eventually led to the creation of Chapter 58, it was much like the federal debate. Should we try to address the two major issues? Find ways to deliver better health insurance coverage, one, and two, find ways to deal with the underlying cost of care trend. And I believe the answer to this was really the only one that could have been done, and that is, let's deal with the insurance coverage first, get people covered. That's easier. We're basically throwing money. I shouldn't say throwing money. We're applying money to this particular important objective. The second objective, dealing with the medical cost trend, is what we're all trying to deal with today. Very difficult. It will impact us all as consumers, and it will be very, very difficult without a doubt for everyone. Certainly for our elected officials, this is a time where I can assure you, you will be challenged by issues perhaps far greater than any other issue as an elected official. So today we're very fortunate to have three top professionals who have lived through this healthcare reform, who are in positions that are significant, also to dealing with how do we get control of healthcare costs that are rising. Excuse me. So each of them will take about 10 to 12 minutes, I'll be the clock watcher, to provide comments from their perspective. One representing the the provider side of the equation, the hospital industry in particular, one representing the payer side or health plan side, and third, one representing the connector, kind of the government distribution perspective on things. And then after that, we'll have time for questions. I know we'll have somebody roving around with a microphone so that we can take those questions as they come up. So let me introduce, if I may, our first panelist, Lynn Nicholas. I will tell you, Lynn Nicholas is the president of the Mass Hospital Association. Laura Pellegrini is the president of the Massachusetts Association of Health Plans, and Glenn Shore is the executive director of the Massachusetts Connector. So Lynn's background. Lynn, as I said, is the president of the Mass Hospital Association, and she has been the CEO and president since August of 2007. When she came into the thick of things, for sure, in implementing the healthcare reform here in the Commonwealth. Prior to the MHA, Lynn led the American Diabetes Association, and prior to that, she served as president and CEO of the Louisiana Hospital Association. So we both share a little bit of Southern blood in us, I guess. Following her tenure there at the Hospital Association, she was EVP and COO of the New Jersey Hospital Association. She also spent 20 years working in a New Jersey hospital where she progressed from a medical technologist to a senior vice president. I always am enamored with someone that can begin right there in the ranks and work her way up as you did, Lynn. Lynn has been very involved in numerous initiatives that focus on health insurance, that focus on payment reform, that focus on medical care delivery transformation, all here in the Commonwealth, led by a variety of leaders. I won't go into that, but I think what that speaks to certainly is her voice matters. Her voice is clear and articulate. She represents a very important part of our economy, the Hospital Association. She also represents a part of our economy that's driving a good portion of our health insurance expenses up. So please join me in welcoming CEO of the Mass Hospital Association, Lynn Nicholas.
Thank you. It's very good to be here this morning. I've been back in Worcester now in 3 business days. This is my 2nd trip back. So if I can just figure out that traffic circle downtown and get that 3rd exit right, it will be much easier to come. It is very clear, as Eric stated, that healthcare is undergoing a metamorphosis that is rather unprecedented. And we use the term the new normal a lot in the hospital world. You know, all the focus is on what's happening in Washington, but I believe, and many of my colleagues in the hospitals believe, that what we are doing here in Massachusetts will have far more impact, be far more successful in wrestling this, this beast of the healthcare cost conundrum than anything that happens in D.C. So I'm going to focus a little more on the state right now. And as you've seen in many respects, what we've done here has been modeled at the national level anyway. Just to make sure everyone has a very clear baseline, I just want to give you Hospital Reimbursement 101. And in a way, I'm speaking for all providers, but specifically through the lens of hospitals. Hospitals get paid basically in 3 buckets. The first bucket is Medicare, Medicaid, and other state programs like the Connector, the one that Glenn adjudicates, as well as the insurance that pays for military and government officials. And Medicare, as you know, is for over age 65 and those with end-stage renal disease. Medicaid is for more indigent population, particularly focused on women and children. And 36% of the care or the revenue that comes through hospital doors is for the Medicare program. Another 14% roughly for Medicaid, and another 7% for other state programs. So basically, when people say, I don't want government messing with my health care, 57% of the care rendered in hospitals right now, and the number is growing and will only continue to increase, is funded by the government. That's important because, as Eric said, the government doesn't pay its share of that care. In Massachusetts, Medicare pays about 92 cents on the dollar of its tab. Medicaid pays about 77 cents, and so that difference has to be made up somewhere. Hospitals are largely not-for-profit organizations, and even if they're investor-owned, they have to get capital and resources somewhere. So you, the business community, by and large, help pick up the rest of that tab. And private insurance can, in Massachusetts, be as much as 130% more, 30% more than the actual cost if you were paying your fair share. So that is a very large policy issue that health plans and providers are aligned on. And that cost shift is something that has been worsening, but I think has the potential to improve. The thing that's important about all of that is that we do have to get the cost base down. And we have some success stories in that regard. In the trend for hospitals in terms of the expense growth rate, and you can compare this to your understanding of the economy from where you sit. From 2004 to 2008 had been running just under 9% on average, 8.6% year-over-year increase. From 2009 to 2010, the average dropped down to 1.5%. That's an 83% drop in trend, which equated to $3.4 billion not spent that would have otherwise, had we not been all focusing on bringing the costs down. Now, obviously, the recession had a great deal to do with that as well. And I would point out that most of the gains, most of the way those costs were saved were in labor, because 65% of the payroll or the expense of any hospital is its labor component. So it's a dicey thing, because we want to create jobs in small business, we want to get cost trends down to save jobs. On the other hand, generally speaking, the easiest way, because there's a lot of fixed assets in the healthcare field to get costs down, is to disemploy people, not employ people, and then that creates to the job loss. So you can see how challenging, difficult all this is. However, we do have a plan. We have a unique way that we are trying to deal with this in Massachusetts. And back in July of '09, I served on a special commission established by the governor and the legislature on healthcare payment reform. And we, after a long process, decided that paying for healthcare in a fee-for-service environment, where you pay for every procedure, every doctor's visit, every click of a radiologic instrument, every slice of a surgeon's knife, or every pull of a laser, is not the way to pay for healthcare. It breeds an incentive to do extra volume. At the very least, there is no incentive to do less and to do better. And so we realized that we have to dramatically change that paradigm in Massachusetts. Now, we thought, we basically recommended that we go to global payments, we go to paying for care through episodes of care and bundles where you may pay for a procedure or care, and the provider is responsible with the payer negotiating a rate for that care for, say, 90 days leading up to the procedure, during the procedure, after the procedure. That's kind of a bundled care. Global payment is really a form of capitation, where it's a payment per member per month, and for a fixed amount of money, on average, you're supposed to try to organize and care for everyone over that period of time. I believe that this can and will be very successful, and 2 years later, the market is beginning to move very aggressively in this regard, and the health plans, including Harvard Pilgrim, which Eric represents, are all designing benefits and working with providers on a voluntary market-driven basis to do that. Laura Pellegrini may elaborate on that a little bit, but we believe that we will, in fact, have legislation passed in Massachusetts, probably sometime after the first of the year, that would codify and promote some of that, and also put some of the tools and resources and measures and standardization in place that would make that move somewhat more successful. I also want to say that we have been working, the hospitals, with health plans and several of the business groups on a very broad vision that would set some very global goals about the cost trend. Now, we haven't, released this in a formal fashion yet, but it's out there enough that I want to mention it. And you've heard the old adage, what gets measured gets improved. And so there's a sense that as a Commonwealth, if we set goals for medical expense, total medical expense, which is not just the hospital care, but it's your pharmacist, it's the out-of-pocket things that you buy. Yesterday I bought calcium supplements. It's visits to the physical therapist. It's acupuncture. It's whatever you do for your health care needs. That's total medical expense. It includes both the price of care, wherever you get it, and it includes utilization, how much care you get and what kind of care. And so we know that medical trend, that total medical expense has been running on average about 2% above the gross state product. The gross state product is just the state version of gross domestic product, or GDP, which you often hear about. And there's another nuance called potential gross state product that takes into account recessionary and inflationary smoothing. And our goal, we are talking about, and we're actually going to propose that this perhaps be in legislation, that we set a goal of trying to get that gap between the trend line and GSP down over a period of time. And we're thinking if we could drop it by 1%, which is billions and billions of dollars, within 3 years, get it down to GSP within 5, hold it there for about 10 years. We could take about 30% of the expense trend out and down in a very rational, market-driven measure, but with a lot of transparency and a lot of focus. And that's not easy to do because I heard Congressman Frank once talk about, he was actually talking about the military, but it's applicable to healthcare too, is that the expenses and the little nuances of where you can save money, it's not like fat that can be trimmed off a steak and it's easy to lop off. It's marbled in. It's marbled in a very fine way that takes a lot of stakeholder effort to change. So I just want to give you a couple of examples from here in the Worcester area of how some of these market-driven initiatives are playing out. I talked to both St. Vincent's Hospital and UMass Memorial, which obviously are two of my members in the area, and they cited a couple of things. One, all the health plans, Eric's and the other two plans, are beginning as a precursor to move towards a more robust global payment scenario, are offering tiered products where you basically choose where you go as a consumer. You have more of a reason to choose the plan you do because your out-of-pocket may differ, and the tiering is based on quality measures, outcome measures, and cost measures, or at least we hope they're based on all three and not simply on cost. And it influences where people get their care. And they may choose to go to a more costly provider, but generally if they do, they would choose to pay more out of pocket for it, just like you might choose to drive a Lexus versus some other car. And the key to all this, though, is that you have to have good outcomes and you have to know what you're paying for. The Polar Beverages and Bowditch and Dewey and Seven Hills Foundation are using benefit designs like this, and I think these will be more common. UMass Memorial talked to me about a program that they have created with the City of Worcester called City Advantage, and it's basically a chronic disease management program for those city employees who have diabetes, congestive heart failure, and other conditions like that. They have done the same thing with their own population within UMass Memorial, which is huge. Usually hospitals are among the largest employers in any city, called Employee Advantage, and they plan to roll out similar products that would be available for other businesses. So I just want to say that hospitals are working very, very hard to bend the cost trend. They are embracing and innovating. They're using business techniques like Lean and Six Sigma to take cost out of their system and re-engineer what they do. And I think that we can be successful, but it's going to take all stakeholders. It's going to take specifically employers, those who make the purchasing decisions, to design very different benefit programs and basically have their employees, and people don't like the term skin in the game, but it's football season, so what can you say? They're going to have some skin in the game in terms of the decisions they make. We can no longer afford as a society to have it all, have what we want when we want, and not expect to pay for it. Hospitals will do their part. The health plans are working at this, and I think government continues to stir the pot. And I'm sure I'll have an opportunity to give you more examples and talk more about this during the Q&A, but I know you want to hear from my colleagues, and so that's my big picture on why I think Massachusetts is going to be more successful at this than the federal government, at least in the foreseeable future. Thank you.
Thanks very much, Lynn. Just one comment I would want you to think about as we go through. And by the way, Lynn does represent the Hospital Association, but I also see my good friend Jack Dutzer in the back. The physician side of the equation in all of this has been quite dynamic in looking for new innovations. In fact, it really is the physician side of the house, no offense, Lynn, that is the most critical in all of this, in my view. They have the power of the pen, and it can go in either direction. And it's good to see how the supply side of the equation is really looking at innovative ways to change how care is delivered. Let me give you this just to ponder before kind of the demand side or the payer side of the equation comes up. I often hear people speak about the health care industry as a market. In my view, it couldn't be further from a market. If we remember from our economics 101 days, there's supply, and then there's demand, and then there's price. And if the supply goes up, usually the price goes down because there's a lot of stuff there, right? And if the demand goes up, the price usually goes up. Well, in the healthcare industry and the health insurance industry, I would say that the major demanders here are us as consumers and the referring physician. And consumers and physicians who are referring, largely in the last 20 years, have not had information, transparency, as Lynn mentioned. If you don't know the price or quality of what you're consuming, then it's not going to be a market. And therefore, the supply side of the equation, and we know there are many dominant healthcare providers out there that have a wonderful brand or a geographic stronghold, are able to draw in a price that's very high. Why not? The demand side of the equation is not really, doesn't really care about that price, largely. So just keep that in mind as I introduce Laura Pellegrini to the podium. Laura, as I mentioned earlier, is the president and CEO of the Mass Association of Health Plans since 2009. Prior to that, she served on the staff of 2 governors, most recently as chief advisor for government affairs for Governor Deval Patrick, and on the legislative staff under Governor Michael Dukakis. She was also Assistant Attorney General in the Consumer Protection Division under Attorney General Scott Harshberger. Prior to Governor Patrick's staff position, Laura served as Vice President for Government Affairs and Community Relations at Harvard Pilgrim Healthcare. While in that role, she oversaw government relations for the 3 states in which Harvard Pilgrim operates, Massachusetts, New Hampshire, and Maine. Laura has a bachelor's degree from Wheaton College and a JD from New England School of Law. Very, very active in the Commonwealth, particularly around payment reform, insurance reform, and everything that matters to all of us. Also plays a very pivotal leadership role in the area of the Massachusetts Women's Political Caucus. Please join me in welcoming Laura Pellegrini.
I want to thank the Research Bureau for having me this morning, Roberta. Thank you for this program and my opportunity to speak. As you can tell, I had no voice last week. I'm doing a little bit better this week, so you're going to have to bear with me. Eric, I don't think mentioned, he is the new chair of the Mass Association of Health Plans, so he is my boss. So hopefully I will cover all the key points this morning. Although I was laughing as he was speaking, he took most of my points and most of my talking points for this morning, but that's fine. I was really intrigued by the title this morning, Healthcare Reform, Is It Healing Massachusetts and the Nation? It's really a 2-part question. I think we've done an amazing job, as Eric and others have indicated, in coverage. About 98% of our citizens in Massachusetts are covered. The problem is, can we afford it? We are facing one of the most significant recessions, certainly in my lifetime, really very, very close to almost a depression. I heard a statistic the other day from a pollster who even he couldn't believe this, that 40% of Massachusetts residents say that their mortgages are underwater. So even in a state where our unemployment rate is much better than the national average, and we think that we've sort of, in some ways, escaped some of the trauma that other parts of the country have seen, if that statistic is true, it just shows the kind of peril we're in. And what we have from Massachusetts health reform and what we're going to see as part of the national reform is an obligation on individuals to have insurance and on the employer community to provide insurance to their employees. Eric mentioned in Massachusetts the rollout of health reform in Massachusetts made some critical changes that affected the employer community. One was minimum credible coverage. As somebody who watched health reform and was really a part of the discussion in Massachusetts, I think when you saw the former Governor Romney talk about health reform, he really saw, and the analogy he used was the Travelocity of health care. where employers and consumers could have a wide range of insurance products that they could have at their disposal to buy. And I would make the analogy, if you wanted to stay at the Holiday Inn, there would be products that would be like a Holiday Inn, certainly fine, but not fully loaded, and products similar to staying at the Ritz, where a little bit more luxury, a little extra, and you pay for that. What we saw during the implementation of minimum credible coverage is actually a raising of the standards for coverage in Massachusetts, including, and I make no value judgment about this, but prescription drug coverage was not a part of everyone's policies. It was not a state mandate, but the Connector board, which Glenn is the executive director of the Connector and reports to the board, it was prior to his tenure, actually made prescription drug coverage a requirement for all products sold in Massachusetts. So we have seen an increase in the basic standards that are required for health products sold in the Commonwealth. And at a time when we're seeing the economy sputter, it's not surprising that we have such a focus on cost. We're not doing PowerPoints this morning, but there's a really interesting graphic which shows salaries nationally and in Massachusetts sort of flat, if not going down, yet healthcare costs continue to rise, and it's not, salaries are not keeping pace with what folks are making. Salaries are not keeping pace with health insurance cost. So it's not surprising that the governor and others have been focused laser-like on cost. I think the very future of health reform really depends on whether we can control healthcare cost in Massachusetts. And I say that because I think that for Massachusetts, certainly if we can't, there's going to be a question about whether health reform is sustainable. But I think Lynn and Eric both said the national law is modeled on Massachusetts. And if we cannot get healthcare costs under control, I think this will be a real national question about whether health reform is sustainable. We live in an interesting time in Massachusetts because we really are the incubator for solutions. And I think that there's a real interest by the Obama administration and others to see if Massachusetts can get healthcare costs under control. Again, our story is terrific about coverage, but we have some of the highest healthcare costs in the nation, and that really does threaten our very existence here. Particularly for small businesses, I think for those who self-insure, you're able to escape some of the state mandates, you're able to design your own benefit plans, and you haven't seen the high cost increases that some in small business have. But for small business, they don't have a choice, and they're required to cover all the mandates, et cetera. And for them, it's been very, very difficult during these trying times. The legislature has really been all over the cost question, as well as the governor. And in 2008, the legislature asked the Attorney General to find out what are driving healthcare costs in the Commonwealth. And the Attorney General did an extensive survey. She had subpoena power, subpoenaed records of the insurers and the providers. And she really presented in what was a landmark report what she felt were the drivers for healthcare cost. And surprisingly, those costs weren't driven by health plan administration, which is obviously the thing we sometimes hear about because it's very easy, or the complexity of administrative simplification and how difficult it is to administer different benefit plans and the burden that has on the system. But the number one reason why healthcare costs were high in her office's estimation were the unit costs that were being paid to some providers. And what she identified is that the market power of certain providers, whether it's through their brand reputation or because they have a geographic monopoly, have driven cost in this state. And that is becoming more profound every day because more and more care is going to those high-cost institutions. Sadly, for the employer community, these costs are not based on quality or how sick the patient population is, but it's solely driven by the name brand or the geographic isolation of those providers. So we're not paying for quality at all. We're just paying for the name brand. This was no surprise to the insurance community, and at times folks will say, well, you know, insurers, this was your job. As somebody who's been doing this for many, many years, I can tell you the legislature asking this question and asking the Attorney General to look at this information was really driven by the Mass Association of Health Plans and the plans that I represent. At the time, I was at Harvard Pilgrim, but we were actively and aggressively asking the legislature to get the Attorney General involved and to dig deep into the question of what's driving healthcare cost. We wanted documents to be subpoenaed because health plans can't talk about their individual contracts. But certainly if the Attorney General is requesting those, they have to be turned over. And we knew the answer. We knew that certain providers had driven costs in the state. And unfortunately for the health plans, there's very little they could do because there was a real demand from employers and consumers that they wanted a really broad network of products. In 2003, when Tufts Health Plan had a showdown with a certain provider in the state, the CEO of Tufts Health Plan reported that for 4 days, he really questioned whether he would even have a company left because the provider began a campaign to say, if you want to stay with your doctor, you're going to need to change insurance carriers. So that's 2003. CEOs from some of my plans went down to Washington in 2003 to testify before the DOJ and the Federal Trade Commission about market power in the state and how it was driving healthcare costs. Again, back then, the economy was good, so I don't think as many people were focused on what was going on. But certainly today, and given where we are in the state's recovery in our current recession, these are really critical problems that need to be addressed. So the Attorney General unveiled that. It was a blockbuster report. The governor in 2010 decided that healthcare costs really were an impediment for our recovery. And as folks know, in April of 2010, for the first time in many years, the Division of Insurance actually rejected health plan rates, saying they were too high and were not reasonable. The health plans through MAP, I was about 2 months on the job, it was really a difficult time, sued the Division of Insurance and the governor because we felt that he did not have the authority to reject our rates, that while the rates were high, they did reflect the cost of care in the state. And we argued that we wanted to be part of the solution, working with the administration and the governor. But if market power was the issue, the plans, particularly the plans that I had represented, had done their best to get the best deals they could, and that we needed to take some action around certain providers. The health plans in their suits had to go to an administrative appeal. For the health plans that went to a final decision with the Division of Insurance, they actually won their appeals on every point. Fallon went to a full decision. They won on every count. Harvard Pilgrim went to a decision and won on every count. The other health plans that I represent and Blue Cross settled before a final decision was rendered. Since then, I think we still continue to see DOI trying to artificially suppress the rates of the health plans, and many times the plans are being forced to write their business at break even or at a loss. And through MAP, we continue to push this market power message that there needs to be some limited government intervention to address the market power issues in the provider community. The Attorney General released a second report this year, equally as significant as the first report I mentioned, where she talked about global payments and said, and Lynn talked about payment reform. The governor's filed a bill on payment reform, which would move the system to pay rather than fee-for-service, pay on a budget or episodes of care. And what the Attorney General said was that while this may be a good idea in the long run, in the short term we need some market interventions. And she found that there are globally paid providers today who are among the highest paid providers in the state. So I think it leads one to believe that it's not really how you pay, but it's this issue of market power, that even globally paid providers who are working on a budget were still able to drive very high cost in the system, and until we fix that, we're not going to be able to really address this cost question. The Attorney General recommended, as one of her recommendations, that there be some short-term changes in the payment system and that there be government intervention, although she wasn't clear of exactly what she was thinking. Majority Leader Ron Mariano, who's a very significant player in the House of Representatives, filed a bill a couple of months ago which tried to address this question, where he is suggesting that the highest paid providers in the state get brought down to a health plan's 80th percentile of how they pay hospitals. And at the same time, because there is a distortion in the market, we have a lot of providers who are not being paid adequately to stay in business, and recommended that we actually take some of those providers up to the 20th percentile. This is major government intervention. He sees this as a one-time adjustment, it is sort of what the Attorney General talked about in her report, but again, she hasn't given us specifics. But that was his way of thinking of the way to begin to right-size this marketplace and have an appropriate foundation as we move towards payment reform, because I think it's his belief that it is important that we empower some of these lower-cost institutions and they're able to survive. Again, the Attorney General's report found that there was really very little difference in quality between the highest paid and the lowest paid providers. So when Lynn talked about payment reform, we'll talk about more of that this morning. This is where the governor wants to really change the payment mechanism. But as I said, the Attorney General feels that we need to really fix this foundation of reimbursement before we move to any new payment system. The legislature last year passed Chapter 288, which was a cost containment measure. It was something they said more work needed to be done, but it's what they did in the short term. And in that was a requirement that health plans begin to develop tiered and or limited select networks. And this was a way, from a policy perspective, to start driving volume away from some of the highest paid providers into more efficient providers who could charge less. We've seen some erosion or attempt to erode those products. About 2 weeks ago, there was an amendment filed in the House of Representatives to actually add to high-paid providers as a matter of right to the limited network products. That would have increased rates by about 5%. So that's a real problem, and we need to really be vigilant that we protect those products and allow them to do exactly what the legislature envisioned, which is hopefully employers will gravitate, whether it's tiered or limited networks, because they are less expensive, and we can start to change the way some of the higher paced providers do their business planning. If they start to see that they're losing volume, they may get more competitive on price. For the MAP member plans, I'm going to end now. Paying for quality and not for volume is really a key for us. So we love the governor's approach on global payments, but again, we think the issue, you need to reset the market initially, because we believe high-paid providers, even in global payment world, will still be high paid. We also believe one size doesn't fit all, and there's just not one solution. We have a variety of employers and a variety of needs. So we need lots of product designs, and we need to take considerations of each business into account as we work with them to develop products. More consumer engagement. Eric talked about consumers really starting to engage in healthcare cost and quality discussions. I've told you this morning that some of the highest paid providers aren't the best in quality. I bet a lot of your employees don't understand that. It's the only purchase that I can think of where you can pay a lot of money, but yet the quality is not better. And every other kind of purchase we make, if you buy the expensive car, the quality, there are reports that the quality is better. If you go to a more expensive clothing store, you expect those clothes to last, the quality is better. In healthcare, it's not the same. And so that, and finally, and it was hard because I have a lot of folks in my association who are market-based people who want the market to work. My board does believe there needs to be some government intervention to fix the price distortions that I talked about, that the Attorney General identified, so that we can start to address the cost issue. Again, the issue is not utilization, it's unit cost, and more care being delivered in high price settings. So I hope that has been helpful. Thank you.
Well, I think now Laura and Lynn have provided some very good descriptions of some of the potential changes underway. And broadly speaking, I think what you're seeing evolve are two potential pathways here. Does the government just take over and take charge of trying to fix this, or do we look to the market to behave in a way to address the issues, or is it going to be somewhere in between, and if so, how far to the left or to the right? And this is really the debate going on. Now, we've talked a lot about what's going on here in Massachusetts. It's right in our backyards. It's important. But certainly, the enactment of the Affordable Care Act is going to have a major impact on how we do things post-Chapter 58. And here with us today to wrap things up before we get into the Q&A is the Executive Director of the Connector. Now, the Connector really did an absolutely remarkable job implementing Chapter 58 in a very short period of time. Really amazing from a communications and an education perspective. This is a model. Now the Connector is facing, okay, what do we need to change now that this federal law is in place? And do we go this way, that way, stick to our guns? it's going to be an interesting time, right, Glenn? So let me share a little bit about Glenn, who's the executive director of the Connector. The Connector is an independent authority led by a board that was responsible for implementing Chapter 58. In Glenn's role, he works with a board of directors representing all walks of life, a good broad distribution of the needs of the citizens of our Commonwealth. Before joining the Connector, Glenn was the Assistant Secretary for Healthcare Policy and Deputy General Counsel within the state's Executive Office for Administration and Finance. He was the leading policy point person for the implementation of healthcare reform in Massachusetts. Glenn has a deep understanding and a set of experiences on the issues of the operations of the Health Connector, the financing of healthcare and healthcare reform, and major initiatives that will seek to promote healthcare cost savings. Glenn also served as the Senior Policy Director and Counsel for the Attorney General's Office, where he focused on, yes, again, healthcare as well as energy and housing issues. Glenn holds a law degree from Harvard Law School and graduated with a BA in history from Yale University. Please join me in welcoming Glenn Shore.
Alas, I have to bring this mic way down. Good morning. Thank you all. Thanks to the Worcester Research Bureau for having me. It's a real pleasure to be here in Worcester with three transformational leaders like Eric Schultz, Lynn Nicholas, and Laura Pellegrini, with whom I've had the pleasure of working over the last couple of years on the implementation of health reform, underscoring the fact that while we're very proud of the central role of the Health Connector in the implementation of healthcare reform, it is not all about the Health Connector. Health insurers, providers, advocates, employers, so many others have been a critical part of the mosaic that has resulted in Massachusetts having the highest coverage rates in the nation, over 98% of its people insured, over 400,000 newly insured, and insurance has been a gateway to better access to care, which is, of course, the central theme and priority with the expansion of coverage. It's an investment in our people, it's an investment in the productivity of our workforce, and it's part of what makes the Commonwealth of Massachusetts special, that it's actually undertaken this endeavor, is trying to see it through without the debate being partisan or posturing, but as just a very complicated but thoughtful policy endeavor that continues to evolve over time. Eric provided a little bit of information about the Health Connector, and I'll talk with you quickly about our role in the implementation of health reform and how national health reform and the cost containment conversation in Massachusetts will refine our role going forward. As Eric mentioned, we are a quasi-public agency created by Chapter 58. That means we're in some parts governmental, but in some parts private. We have an 11-member board which reflects this fact, chaired by the Secretary of Administration and Finance for the Commonwealth, represented in part by people who are coming to the Connector and serving on its board by virtue of their positions in government, but people from private walks of life as well, which has really strengthened us, guiding us with diverse perspectives. We've recently really pleased to have an 11th member appointed to our board. This is a representative from the Massachusetts Association of Health Underwriters, a health insurance broker, which will give us even greater insights into the work of brokers and the small and non-group distribution channels. So we're getting stronger by virtue of greater diversity on our board. The Health Connector does 3 or 4 sort of basic things. The first thing is, foremost, it's a health insurance exchange. It facilitates access to private health insurance for individuals and small businesses by basically serving as a market maker, a marketplace where people and small businesses can shop for coverage. It makes some of the central policy decisions under Massachusetts health reform, particularly deciding, number one, we have a state adult health coverage mandate. People are required to have coverage who can afford it. People are exempt if they can't. Someone has to write the rules about who can afford coverage and who's exempt. That's the Health Connector. And somebody also, or some entity also, has to write the rules about what counts as health insurance. This term, minimum creditable coverage, is that. What's the minimum level of health insurance you need that will basically be the foundation for satisfying our state's adult health coverage mandate? That was one of the more complex decisions the Health Connector had to wrestle with in the course of its existence. It did adopt its minimum creditable coverage rules unanimously. They did require that individuals, in order to satisfy the adult health coverage mandate, maintain prescription drug coverage. That was a unanimous vote, including a vote, the support of its small business representative. I think it reflected a perspective that in this day and age, given the advances in medication, that it's indispensable to complete medical care. So even basic health insurance, omitting prescription drug coverage, was incomplete. A recognition that omitting that from the health insurance benefit didn't make the costs go away for anybody who was paying for it. They would just show up in different forms as people didn't have access to medication. They might get sicker. They might show up at the hospital in instances where prescription drug coverage would have prevented that in the first place, and we all pay for that at the end of the day. And it's also a reflection of the fact that, yes, there are some people in the state who didn't choose to have prescription drug coverage. Of course, there are many people in the state who chose not to have health insurance. The core issue of the individual mandate is there are some decisions we're making as a community to ask people to come into the ranks of the insured and, yes, have forms of insurance that they didn't have previously, even if they wouldn't have chose so initially, because they have a shared responsibility to join the ranks of the insured for their own benefit and also for the benefit of the community, because when we don't have the safety net of health insurance, again, we all pay for the health care that results from that fact. So anyway, complex decisions facing the Health Connector. We've also been at the forefront, as Eric recognized, as on the task of educating people about why it's important to have health insurance, access to preventive care, access to a full range of benefits to enable them to stay healthy and protect themselves in the event they get sick. Also in our state, you pay tax penalties for not having health insurance when you can afford it. We had to get the word out. And we've partnered with a variety of different organizations, community organizations, health insurers, providers, the Red Sox, particularly when they weren't having September swoons, to get the word out that health insurance is a good thing to have in Massachusetts. It's a required thing to have in Massachusetts, and I think that's created an environment where people know of the rules. They're largely complying with our coverage mandate, and of course we have the highest coverage rates in the nation. Again, the Health Connector is not the be-all and end-all of health reform, but is a critical part of it. Over 215,000 people purchase health insurance through private health plans through the Health Connector. That's over half the newly insured in Massachusetts. Our coverage decisions implementing the adult health coverage mandate have helped expand coverage even outside our programs. For example, we see employees who might have formerly given up the offer of employer coverage entering into the ranks of the insured, taking up their employer coverage because of the adult health coverage mandate. We see young adults who previously would have passed up coverage because they thought they would never get sick, except some did get sick, joining the ranks of the insured, purchasing our young adult plans because of our adult health coverage mandate. So we have coverage expansion happening through our programs. We have coverage expansion happening as a result of our policy decisions. And foremost, we fashioned a shopping experience through the Health Connector where individuals and small businesses can come to our programs, come to our website, and very clearly see their options in front of them. We take pains to try to structure the shopping experience so individuals and small businesses are really empowered to compare their options on an apples-to-apples basis and choose the coverage that best suits their needs. By putting individuals in a more empowered position to find a coverage that's high value and best meets their needs, number one, we're trying to put individuals and small businesses in place that they could, for example, find more affordable coverage options than they already have. And the theory is that one informed shopper can help themselves, but with scale, thousands of informed shoppers can help move the market. And I think you're beginning to see the seeds of that through the Health Connector right now. We are one of the foremost platforms in our state for an experiment with limited networks. In our state-subsidized programs, which have market dynamics really at place, we have about 48% of our members enrolled in narrower network plans right now, which save the Commonwealth a lot of money. And it's a great learning experience for the Commonwealth about the value of narrow networks to deliver high-quality coverage without compromising people's access to care. One of the benefits of having this experiment play out on a public entity like the Health Connector is we're in a position to monitor it, measure it, report publicly on the data that's accumulated that speaks to, is this just cost shifting, or is this ability of people to see a narrower network of providers and yet still get all the care they need? So I think we're going to help advance the conversation about new innovative coverage and benefit designs in the Commonwealth by being a shelf where people can see their options clearly and select the coverage that best suits their needs, and reward health insurers and providers that work together to structure high-value care and coverage options. National health reform, it's interesting. We all know that national health reform is based on the Massachusetts model, and there's no doubt it is, but national health reform will require the Commonwealth nonetheless to refine its approach. At the Health Connector, we're really pleased that national health reform requires all the states across the country to set up health insurance exchanges just like us. We're flattered, but at the same time, we currently are a vehicle for serving 215,000 people. That's a full-time day job, and at the same time, we're asked to refine our approach for 2014. So it is kind of like driving the bus and changing the wheels at the same time, but we're doing our best. National health reform creates some great opportunities, I think, for Massachusetts, and poses some challenges and opportunities for the Health Connector as well. I think it will make us an even more appealing place for small businesses to look for health insurance. Small businesses receive some tax credits under national health reform. In 2014, if they want to retain those tax credits, they will need to shop through the health insurance exchange. So we're very focused on fashioning a very good shopping experience for small businesses, particularly with an eye towards 2014. National health reform will ask us, I think, challenge us and give us the opportunity to consolidate a maze of state health insurance programs. And I think in doing so, we can get some efficiencies at the state level. I think we can send more consistent signals to the insurer and provider market, and be more of a force in a coordinated way towards driving innovative models such as global payments and narrow networks. One important area of work under national health reform for the Health Connector and the Commonwealth writ large is that we have, as you know, an adult health coverage mandate in Massachusetts. We also have employer fair share rules that Eric mentioned. National health reform has similar individual and employer responsibility rules, but they're not identical. A lot of work that needs to go on in the Commonwealth and the Health Connector in part to mesh those state and national approaches so that we have strong and thorough individual and employer responsibility rules, but don't send people scurrying in different directions with inconsistent rules that are difficult and impossible to comply with. That work will get done, and it will be a focus of the Commonwealth's policy development over the next couple of years. And finally, I think for the health insurance exchange, the Health Connector, to the extent we continue to be a place where individuals and small businesses can really see and easily enroll in high-value coverage and care options, there are natural synergies between what we do and the payment reform conversation, to the extent that insurers and providers are working together, delivering care through vehicles such as global payments, bundled payments, and other approaches that deliver evidence-driven, coordinated care, giving people the care they need at a more reasonable price. The Health Connector is going to be a shelf to display the success of our insurers and providers, and I think will foster competition driving towards innovative payment models. So we're very excited to do our work, which I think will promote and have natural synergies with the payment reform conversation in Massachusetts. I should also say it's really great to be here in Worcester. My wife is from Worcester, born and bred in Worcester. I stayed with my in-laws last night, so it's always a pleasure to be here. It's also nice to see some friends and colleagues from Fallon Community Health Plan, really obviously a great institution in Worcester, a real great partner for the Health Connector. I saw Yana, Sonia, Jesse, and others here. It's a pleasure to work with them, and I know they're a real asset to the community, as Harvard program will be. And Eric has a rich history in here. I'm being careful. Anyway, thank you all.
Okay, nicely done. Let's open up for some questions, and Jean Diesa with the green scarf will hand you a mic. Sir, in the back. Jean, right behind you.
Hi, my name is Randall Ormo from Worcester. I am going to be here representing myself as a consumer. You keep on talking about costs. To me, the problem is not more with, it shouldn't be market-driven from my own position. The world has changed with technology. The cost of health has gone up drastically because the cost of medications has gone up. Technology changes. We're living longer, so diseases that weren't prevalent 50 years ago are prevalent now. I think we need to take a look maybe at changing and looking at how we pay for what we get. And I'm not talking insurance-wise. I'm talking about where the money comes from to fund it. That's number one. Number two is the fact is that I think we should be looking at, and I'd like your response on going to a French-type plan, which is that there's a basic coverage for everybody, and then you go to insurers for extra coverage, like you'd say, for the elderly with Evercare. And the thirdly is that I have a problem with the way, no disregard to the Mass Health Connector, that you have a tiering system right now that puts the penalty on the individual rather than on the healthcare institution. When the Obama administration was pushing health care, there was a lot of talk about we're not going to tell people where to go. But the current system in Massachusetts says that if I go to UMass, which is where I go, I am penalized on my copay because they're not the most effective according to the judgment. Why would we not penalize the institution by changing their reimbursement rate rather than have the individual basically pay for the errors?
All right, do you have a prioritization on your questions? Because we do want to offer as many opportunities.
I know
One, two, or
there's a
three.
lot. I'm keenly involved in looking at health
Okay.
care.
Do you have a prioritization?
I would say probably the first one. Why
The
do you
first.
penalize the last one, which is why do you penalize the individual rather than the healthcare institution in the copay?
Got it. Thank you for your questions. I swing it over to the panel.
This is a very small mic. I couldn't agree with you more. I think that we've had the Attorney General's report out now for about 2 years. The fact that there's been no government action, I think, really speaks to the power of some providers who do have this quote-unquote market power to really direct the conversation in the legislature. I think select and limited networks and tiered networks definitely have their place and for consumer engagement and to offer a lower priced option to some employers. But I do agree with you that if the legislature and the governor were to address market power and to look at something like the Mariano proposal, there's going to be a report coming out from a provider pricing commission over the next week or two, and there'll be some recommendations there. If we were able to do something in that regard, I think you would see that we would finally start to address unit cost, and I think it would bring you and others some relief. So that's my comment.
I'll take a stab at that as well. Actually, the tiering networks and the narrow networks and some of these intermediary steps that are in place now, I think is precursors to paying for care very, very differently in the future, do actually provide disincentives to both the consumer and to the institution. Because those institutions that are not in some of the tiers are losing volume, they are having to make adjustments, they are reorganizing their care, and they're all scrambling. Everyone is scrambling to get their costs down and do a better job of the care they're delivering. Just a quick note, Laura did a very good job on talking about the fact that there is no relationship between the quality of care and the payments. And that's for two very, I think, reasonable reasons that we can and should change in the future. First of all, historically, there was never any way that payments were designed to be tied to outcomes or quality of care. In a fee-for-service environment, everybody just got paid for doing what they did, and so it's absolutely no surprise in Massachusetts or in the other 49 states that there is virtually no relationship between the two. The second is that all the quality measures that Laura was talking about are publicly reported measures, and almost all of them are process measures. We, in Massachusetts, hospitals are far above the nation on average on process measures on all of these measures. We exceed the nation, and the health plans here also exceed the nation and are award-winning in terms of the quality of their offering, and that's just part of what we get in Massachusetts. So what we really need to focus on, and the academic community I think, understands this, is that we need better measures of quality that really relate to outcome, because the good news is that at least on the measures we have, you can get very, very good care anywhere in Massachusetts. And that's why these narrow networks and limited networks and select networks, I think, as Glenn pointed out, are a good experiment, because as people do choose those options, so they at least have less money out of pocket, I think they will find that they get very good care indeed. So I think my bottom line on it is something I said earlier. This cannot be fixed by whacking away at the hospitals and providers and physicians alone. Everyone has to play a role, the stakeholders, the employers who purchase care, the consumers, government, and the providers. It's really going to take a shared responsibility, just as we did in coverage, and you can't pin the donkey on the tail of any one of those as the perfect solution.
Thank you. Other questions? Connie?
Thank you. Connie Luce, I'm on the City Council. The City of Worcester has saved literally millions of dollars in health care costs because we shifted the cost to our employees, increased contribution to the premiums, and increased the tier costs, et cetera. The fear is that because of the economic climate we're in, that our employees will be less likely to seek out services that they would have in the past. So my question is, what role does preventative medicine, does alternative medicine, and do wellness programs play in this whole scenario?
That is a very legitimate question, and that's something that we need to watch very closely, and why the data, in fact, Laura and I have been advocating very strongly that an all-payer claims database, which is all the claims for all kinds of care, be readily available and researchable, and that we all pay a lot of attention to who's getting care and when and for what. The role of prevention and wellness is incredibly, incredibly important. The trouble is that it doesn't have an immediate payback. It doesn't pay off in the short run, and so it's something you have to do because it's the right thing to do, and it will be the right thing in the long run. But short term, it can actually increase costs depending on how you're measuring it. I think the real answer is it's the 20% of the population that has chronic disease, has diabetes, congestive heart failure, asthma, diseases like that. Those drive 80% of the cost, roughly. And so what we need to do more, instead of worrying about everyone in the same way, is really focus our attention on chronic disease and the drivers. And the health plans are coming up with innovative products and ways to do that. I didn't mention, I did mention the thing with the City of Worcester that one of our hospitals is doing around chronic disease. So what you mentioned is important, and we need to do it because it's the right thing to do. Quite frankly, the big payoff will be a lot more focus on those patients and consumers who most drive the cost and have the poorest health and who would benefit the most from unique investments.
As part of the healthcare community, obviously, we're going to do ourselves a huge disservice if people are avoiding care because they can't afford it. And those costs will be much more expensive at a later date when they choose to get care. I think in the tiered products, it really is a way that the legislature sought to start to be able to involve consumers more in their purchasing decisions, to really look to see if the name brand, are you willing to be in a higher tier and pay more, or are you willing to start to do some investigation to find those very efficient providers who are high quality but lower cost. So it's a way to start to change that conversation with consumers and also give providers pause to say, you could start losing volume if you don't start addressing the cost issue and improving your quality. Clearly, we need more transparency in the system so that employees can start and individuals can start looking at data and looking at cost and quality metrics so they can understand, particularly for elective surgeries. My mom last week had to have her gallbladder out. Very hard for me to figure out where was the best place for her to go, who has the best outcomes for her. We really need, if we're going to involve consumers, we need to have that kind of information for them. But again, I think the limited networks and the tiered networks were a response by the legislature, a response by employers to deal with the cost issue. If we were to believe the Attorney General's report around unit cost, and if we were to find a government solution to address that more directly, I think that we'd be able to take a lot of the cost out of the system, and these other kinds of products would support that endeavor. But again, unit cost and market power seem to be, from the Attorney General's view, the number one reason why we have high healthcare costs in the Commonwealth.
It's hard to bite my tongue up here as the moderator, but one point I do want to add to this, and this is a dynamic that is occurring not just here in the Commonwealth, but across the country. And it's actually a frightening dynamic, and that is the trend of medical cost is actually been diminished in the last year or so because of this recession that we're in. People are choosing to not get care because, one, they're afraid to take time off from their jobs and risk losing their jobs. Two, there is a high amount of out-of-pocket expense already and they can't afford it. There are a number of reasons why utilization levels are down remarkably. This is across all insurers. Now the challenge is, one, we shouldn't be dancing in the streets seeing a lower medical cost trend and saying it's because of all of these innovative plans and these innovative cost management strategies of the payers and the providers. Those are valuable. But what we need to understand is that this trend is down, and it's our argument that there is a growing pent-up demand for care. And as the economy improves, so too will be this utilization pent-up demand. We need to be ready for this. This is going to be a double whammy at the same time that we see some other things emerging out of the recession. Just another point of good news. Other questions? Russ.
Russ Vandervaan from Siemens. Eric, Harvard Pilgrim is affiliated with United Healthcare. And if I'm not mistaken, within the last week or two, Forbes had a report of the top paid CEOs in the U.S., and I think that the CEO of United Healthcare was the number one, and I think I just saw a flash on the news. He was making $130 million a year.
Wow.
So is there a disconnect? Is there a disconnect between, cost reduction and compensation levels like that?
Well, I'm just a CEO of a not-for-profit health plan in Massachusetts, so my calculator doesn't go that big.
Eric, I'm happy to sort of address that.
Yeah.
I think...
Well done. Good question, though, Russ. It is
Eric,
important.
how am I doing in my job?
Let you know when we're done.
I think oftentimes folks will focus on salaries of top executives and try to paint a picture that that is the reason why we have high healthcare cost. I have to agree it doesn't send the right message from an image point of view. But that is not the reason why we have high healthcare cost. Again, I'll go back to the Attorney General's report. Lynn makes fun of me, but it is the best thing I have going.
She's the official spokesperson.
She thinks we're related. Not yet. But really, when she went to answer the question, what are driving high healthcare cost, she could have answered that in a variety of ways. They subpoenaed documents from the health plan, subpoenaed documents from the hospitals and physicians. They took depositions. They really could have answered this in a variety of ways. They could have said it is CEO salaries that are driving the cost. That is not the answer. That is nowhere in the report. The number one reason why we have high healthcare cost is the market power of some providers in this region to drive cost. So I know many of my friends at Healthcare for All and others want to cite CEO salaries, and I think it's provocative and it's interesting, and if they were smart, so we can move ahead in this debate, they'd probably take a salary cut, but it's not the reason. But it does obviously create an image problem.
Russ, though, I think there is a disconnect with some of these outrageous salaries. I didn't want to, play it down, but I think there needs to be something there.
That question of the issue of malpractice insurance, I thought I would go to the CEO.
Well, malpractice insurance needs to be dealt with as well, because I feel bad for any physician who has been impacted by a lawsuit and how it impacts her or his career. It really is driving utilization. Yes.
Eric, I would have liked to have seen on the panel someone from either Society, or the State Medical Society,
Mm-hmm.
just because they're the providers. That's it.
Mm-hmm.
Now, a lot of the plans are including, and you mentioned it, the prescription part of it. Now, the prescription part of it is no substitution sometimes from the physician. However, are you checking the people that make the generics? You know, the things that come in from the Philippines could be sold in thousands of drugstores here. Maybe they're not the quality it should be. No one's checking that. Not alone, they're not checking the patent ones either. But the point is, it's very critical that you get that drug into your system in a way that really gives you an effect. There are times, and they've come back and told me, that prescription drug came out in their daily duties in the bathroom, intact. Now, I want the folks to be able to guarantee that those prescription drugs being sold by Mylar and the rest of them are in good shape and gives you the therapeutic quality that the physician that wrote for it is looking for.
Thanks, Jim. Who wants to handle that one?
You must have heard the same segment on National Public Radio that many of us heard this morning on that issue. You know, that is the role of the Food and Drug Administration, and I think, to your point, as the role of generics increases in this country and as the number of drugs that have historically been on patent come off patent, I think the FDA has understood that it needs to really step up its review and scrutiny. And when a given pharmacopoeia regimen is not working for an individual patient and can be documented, then that does need, the physicians need the latitude to make those changes. Healthcare is becoming increasingly customized and personalized, which is a kind of contradiction to some of the standardization that we're facing. So it's an important issue. I think it's beyond the ken of any of us to address, but as the world evolves in that regard and more drugs come off patent, I think that there will be more scrutiny on that issue and more transparency for both clinicians and consumers around that issue.
Well, with that, it is time up, and I didn't give the one question warning. Thank you all for joining us here. Thank you to the Worcester Regional Research Bureau for bringing this important subject, and especially my thanks to my professional colleagues. Please join me in a little applause for their attendance here this morning. Good to see you all. Have a wonderful day.